started. All right, students, thank you so much for joining us this evening. We're going to give it a few seconds for you to come into the room. For some reason, Zoom slowly lets people in the room. It's very weird, but thank you so much for joining on this Monday evening. We're going to have a great program for you tonight. We'll give it a few more seconds. The number is slowly increasing. Students, thank you so much for coming. Yes, Annie, thank you for all of this. Thank you. Thank you for coming. We love the feedback. Everybody, the chat and the Q&A are definitely open tonight. We have got a great program for you. Really quick as far as introductions. My name is Dr. Cameron Matthews. I'm a family physician by training, and I'm one of the founders of an organization called Tour for Diversity in Medicine. We are a nonprofit that basically tours the country and tries to motivate Black and Brown students all around the country, and actually a little bit around the globe. We're kind of proud of that. We're getting a little bit of extra reach. And we are really proud to be partnering with the Student National Medical Association and the Latino Medical Student Association these past couple of years on a program called Road to Residency. For those of you who may not have heard of it, we match up fourth-year graduating students with faculty, senior residents, fellows from their respective field to have a mock interview to get prepared for the upcoming residency application process. And we usually host specialty-based workshops along with that. This year, we are absolutely happy to host a special event called A Career in Radiation Oncology, because unfortunately, we didn't fit this in during our Road to Residency program earlier in the year. But the goal, because we didn't necessarily have an audience, is to make sure that all of you guys actually apply and get to where these fabulous physicians are. So without further ado, I'm going to hand it over to our amazing panel. Thank you guys so much for talking with our students tonight, and I'll let you have it. Thanks so much for joining.
Thank you so much, Dr. Matthews. Thank you everyone for joining us tonight. Today I'm Alexandra Diaz. I'm an associate professor and vice chair of DEI at the Ohio State University, the James Cancer Hospital. And today I'm with an excellent group of panelists, and I'm very excited to have them here today. So we have Dr. Rachel Jimenez. She's an assistant professor at Mass General. She's also the chair of the Quality and Safety Committee, and she was the past associate program director. We also have Dr. Zachary White. He is a PGY2 at Stanford, and Dr. Malcolm Mattis, who just joined, who was having some technical issues, will also be joining us today. He is an associate professor at Rutgers. So thank you so much, everyone, for joining us. I'm going to start with a brief PowerPoint introduction, just to share a little bit about what radiation oncology is, and then we will go more to an open Q&A question session and go from there. So we'll see if I can share my screen and do everything right. Okay. Okay, so can you all see? Okay, so radiation oncology, a hidden gem. So first of all, some questions. So the reason why we have this presentation today is because I think several people, most medical students, even myself, when I was a medical student, had several questions about radiation oncology. Is that even a specialty? You need a lot of physics for it, right? Those are some of the questions I have been asked. Do you see patients? Is it a field where radiologists only focus on oncology? So those are kind of the questions that we want to address. So first of all, if we look even at the AMC description of radiation oncology, so radiation, it says radiation oncology. A radiation oncologist uses ionizing radiation and other modalities to treat malignant and some benign diseases. Radiation oncologists may also use CT scans, MRI, ultrasound, and hyperthermia as additional interventions to aid in treatment planning and delivery. So with that definition, I'm not really sure I know what a day in a radiation oncologist looks like. So I'm going to start talking a little bit about radiation therapy. So radiation therapy is the use of photons, protons, or other high particles to kill cancer cells. And the main way that radiation helps to kill cancer is to causing DNA double strand break. So that's the background. So radiation therapy can be used as neoadjuvant therapy, adjuvant therapy, definitive treatment of cancer or in the oligometastatic setting, or not for non-oncologic treatment. So for patients, not necessarily for patients with cancer, so other benign diseases. So this is kind of, I just wanted to show how a LINAC works. So a LINAC, So a LINAC is a linear accelerator. Is probably the machine that we use the most to treat cancer. So basically it's a machine that rotates around the patient, and it's, let's say this is the cancer. So the machine rotates around it and delivers the beams from multiple angles to try to adjust, be conformal to the shape of the tumor. So this is how we deliver most of the radiation therapy. So what do we do? So I just want to share this video to start with about considering our career in radiation oncology. So this is a video put together by Astro. So let me see. Can you hear? Yeah. No? Oh, okay.
It's muted.
I can hear it, but okay. I don't know what to do. Well, I will add it to the chat later so you can all see it later. So let's go back to here. So basically, considering a career in radiation oncology. So we have clinics. So what a day in what an unusual day looks like. So we usually have clinics. So when a patient has cancer and the medical oncologist or the surgeon identifies that the patient may need a radiation therapy as part of the treatment. So the patient is referred to us and we see them in clinic. We see them in initial consultation. So first, yes, we see patients in clinic. We have usually, we have a clinic day like most specialties that have clinic 8 to 5, 9 to 5, 9 to 6. And then we proceed with the CT simulation, which is a CT scan specific for treatment planning. And then I'm going to show an example of contouring a lung case, just to show you what we do with the. So first, we evaluate the scans and we look at the tumor and we contour where the tumor is. And we also try to contour the structures, the normal structures that we want to avoid. So basically, and we then evaluate, like for example, for lung, we evaluate during the breathing motion, how much the tumor moves, and we evaluate that to create our ITV and then our PTV, like our target volumes. So then, let's go back to this. So then we proceed, so then we plan a treatment, and this is kind of like the isodoses, like the dose, the red part is like where the dose is the highest, and this is the dose follow-up. So there is lower dose here than in the center. Obviously, this is a brain, the other one was a lung, so it's not the same case, but just to show as an example. So far what I have talked mostly is about the external beam radiation. But in addition to the external beam radiation, which is the one that's delivered by the machine, I showed in the beginning, the LINAC, we also do brachytherapy. So there are two, I'm going to show a little bit about what brachytherapy is, but it's basically the use of internal radiation. So here, I'm going to try to show, particularly since we don't have volume. Okay. So I'm going to show an example. This is an example of brachytherapy for the treatment of cervical cancer. So this video is going to show the patient is positioned, and then we use an applicator to go inside the cervix and get closer to the tumor. So here it shows the tumor, and we place the applicator, and we are going to deliver a high dose to the tumor. So we place the applicator, and it's going to show the other part. And once it's set in the right position, this is connected to the machine, and then radiation therapy is delivered internally and in very close proximity to where the tumor is. So then, as for example, for cervix, it requires several treatments, but then the tumor regresses over time. So that's for cervical brachytherapy. So yes, we do procedures. Cervical brachytherapy is one of the procedures, and brachytherapy for treatment of prostate cancer is another one of the procedures that we do. So we treat prostate cancer in a definitive setting. But basically we insert some seeds inside the prostate. So it can be through the seeds, or it can be with some applicators, and we deliver high dose of radiation to the prostate to treat the prostate cancer. So again, so to summarize what I have talked about so far, so we do some clinic. We also plan the treatment for external radiation, but we also do some procedures with the use of brachytherapy. So these are some examples. We also place markers of, I treat GU and GI cancer. So I treat prostate cancer, and I also do the procedures to insert these gold markers to make sure that we see where the prostate is every day during treatment. So this is at the time of the CT scan. This is what it looks like in the low dose scan that we do every day to make sure that we're treating the right spot. And this is how it looks like the images superimposed. Okay, so this one, since the volume wasn't working, I'm not sure. Let's see what we can do with this. Well, one second. So basically, this is one example of treatment of benign diseases with the radiation therapy. So let's see if I can just jump. So we use it for the use of VT. So we treat with high doses of radiation. We can treat the focus of arrhythmia in the heart. So this is just to show that we do not only treat patients with cancer, although it's most of the patients that we treat are patients who are diagnosed with cancer. We also use radiation for the treatment of some benign diseases such as arrhythmias. Okay, so we have talked about the clinic, the procedures, the treatment with external beam radiation. We also have some role in research. So it can be basic science, it can be clinical research, or even, this is just to show that for example, I'm involved with the Center for Cancer Health Equity at OSU, which works on increasing cancer awareness in the community with an emphasis on increasing participation in cancer clinical trials. So we also do some outreach work. So we can also be involved in some outreach activities as well. So this is another video by Astro that I think I'll just add it to the chat for you to be able to assess later. Which it's just to show what the future holds for radiation oncology. So, any questions so far? I'm going to try to escape and stop sharing. Okay. Okay, so I'm going to well, so now that I have to start with that brief introduction, I would like to, so I may ask some questions to the panelists about their experiences. And I'm going to start with Dr. White. Dr. White, you are a PGY2 at Stanford. Would you mind sharing your, first of all, why you decided to go into radiation oncology and what a day looks like?
Sure. So hello, everyone. My name is Zachary White. As was previously mentioned, I'm currently a PGY2 here at Stanford. I'm originally from Birmingham, Alabama, and I went to undergrad at Tuskegee University in Alabama and did my studies there at University of South Alabama College of Medicine for medical school. So I've journeyed a long way to get here to Stanford, but it really began my interest in radiation oncology or on medicine in general started back when I was about 8 or 9 years old when my mother was diagnosed with breast cancer. During that time, she underwent surgery, radiation, as well as chemotherapy. And, I went with her to most of those appointments. And, it really kind of impacted me at a young age that I wanted to one day treat patients just like my mom. And as I fast forward, I knew that I wanted to become a physician. And I had oncology in the back of my mind. But it was interesting that I actually rotated and shadowed a radiation oncologist. And it was really impactful to see that you can use, really state-of-the-art technology to treat cancer patients. Cancer patients are a unique subset of patients that we treat because it's really tough to hear the diagnosis that you have cancer. And, to be able to walk through that journey with patients and hopefully transition them from a cancer patient to hopefully a cancer survivor, I think is really fulfilling. And that's one of the things that I think is really important about our field. And all of us on this panel can attest how, our field is very tech heavy, but the most important and essential part of our field is caring for the patients. And that's one of the unique things that I think I love and really gets me going each and every day as I see our patients on a daily basis.
Thank you, Dr. White. And so what does a day look like? What does a day as a resident look like?
So today, for instance, today is my Monday. I'm on my head and neck rotation. So we treat a lot of oral cavity cancers, oral pharynx cancers, laryngeal cancers. So before today started, this past weekend, I had to prep my patients. So that involved me going through the chart, seeing why some of the patients were referred to radiation oncology, looking at their past medical history, looking at their past imaging, and as well as looking at their pathology results to see why we're treating or if we could treat them. And if we were to treat them, what dose would be optimal for our patients? And so today I went through my clinic and saw several patients. A couple of them were new patients. So that's what that prep involves. And a few of them were also follow-up patients. So after the patients we treat, we continue to follow them after the treatment to make sure that they're doing well, to check to make sure that there's no disease present. And if there is disease present, what could we do to create a plan to try to treat them maybe again or refer them to someone else. And then after my clinic, it involves, again, prepping for tomorrow again, but we also have contouring, as you all saw the images, the CT images, where we map out where exactly we want the radiation to go. And we also map out where we want to avoid the radiation to protect those structures that are around the tumors that we treat. Also in my week, we have didactics, which is a multitude of lectures that we attend from our attendings. They present. We're currently on our CNS, central nervous system didactics, and each week we learn about different things related to that. We also have chart rounds. Chart rounds is where we present the patients that are undergoing treatment, and everyone in the department, all the physicians, discuss whether we think it's a good plan or ways that we can optimize the plan. So that's another way of quality assurance that we have in our field. And then lastly, we have OTVs, which is on treatment visits. So while we have patients undergoing treatment each week, we see them to make sure everything is going smooth with their treatments, making sure that if they do have any side effects, we can give them medications or some advice on how to, deal with those side effects. So that's just a little brief summary of what's going on in residency.
Thank you, Dr. White. And before we started, we talked a little bit about cold. So they call it radiation oncology. So do you have overnight call, or how does the call work?
Yeah. So, and just to back up too, in residency for radiation oncology, most of the time it's a 5-day work week, but and generally we have weekends off, but during those weekends we prep and do additional studying. But during call weeks, I am on call throughout the entire week. And so I was previously on call this past week, and that involves, you're the first person, say for instance, a patient comes into the emergency department, they have some back pain, they're not able to urinate, or they have some fecal incontinence, or they have some sensations, paresthesias going down their leg. That starts to clue in that something's going on, and you note that they maybe have a history of breast cancer that wasn't treated previously. And so a scan is performed, MRI scan, and it shows what we know is spinal cord compression, where the tumor is pressing up against that particular, that spinal cord. And that's really an emergency for us. And one of the things that we do is we give steroids to reduce the inflammation from that tumor. We talk to neurosurgery, see if they're a surgical candidate. And then if they're not, then we can give radiation to that tumor to alleviate that tumor compression on that spinal cord, and hopefully preserve some of the function that they had before this happened. So there are a few emergencies in radiation oncology that require us to be on it so that we can really do best for our patients.
Thank you, Dr. White. So I would just want to add, and I will ask Dr. Jimenez and Dr. Matis also to let us know how call week works at your hospitals. I would say it varies from institution to institution. At OSU, the residents, while they are doing their call week, they are not doing any of their outpatient work. So we have a high volume of patients that are currently admitted. The cancer hospital has a high volume of patients, and we are in charge. They are in charge of getting any inpatient consults to evaluate patients who may have issues, acute issues like Dr. White mentioned, like core compression, some issues with brain mets, superior vena cava syndrome, and they just have to go and evaluate those patients. But the week that they are doing inpatient consults, they are not seeing outpatients. And the calls, they have to call the phone, but like it's very rare. I think I was called overnight once when I was a resident, and I don't think I've been called as an attending. I've been pretty lucky, I guess. But it's not very common that we are called overnight to come and see a patient. So I don't know, Dr. Matos and Dr. Jimenez, do you want to talk a little bit about how call weeks are for you and for the residents at your institutions?
Go ahead, Malcolm.
Yeah, I mean, generally speaking, most of our emergencies, what we call emergencies in radiation oncology, are a little bit more urgencies most of the time. You're not really like rushing a patient to the radiation oncology department for something. Someone else is sort of stabilizing them first, and then we get involved, for dealing with, bleeding or cord compression, or, there's a few things that, we might have to come in for. But, it's a pretty rare event that, because it's not like it's more of an urgency than an emergency. It's pretty rare that we have to come in at night or on the weekend or things like that. Whether you're a resident or an attending. I mean, we have a little different system for taking the inpatient consults, but it's less dependent on the residents and more on the faculty where we are. But I think it's different when you're have an inpatient service, right? If you're internal medicine or surgery, somebody has to be in the hospital all the time. But when you're more of a consultant for inpatients, like radiation oncology and some other specialties, you take things from home, and usually you're not bothered as often after hours.
Okay, so Dr. Jimenez, do you want to share a little bit your experience as an associate program director? What were the things that you look for in the applicants? What traits do you look at the application? What things you paid attention to?
Sure. So hi, everybody. Thanks for letting me join you. So I'm a radiation oncologist at Mass General in Boston, and up until this past year was a program director for the residency program, and so was very involved with trying to recruit people into our field. And I think that in radiation oncology, to get to Dr. White's point and Dr. Mattis's point, and a lot of what you've heard already from Dr. Diaz, is that the patient care component is really the most important thing that we do. It's really truly trying to care for patients with cancer. And so when we're looking for people to join our field and to be our colleagues in the future, we're looking for people who really truly care about patients and providing oncology patients the very, very best care that they can. So we're looking for people who are very clinically focused, who want to be seeing patients in clinic, meeting them, engaging them, understanding their history, and being really thoughtful about what's the best way to cure this patient's cancer. And if we can't cure their cancer, what's the best way that we can relieve their symptoms and give them a good quality of life for as long as we can do that for them? So I think first and foremost, we're just looking for people who are passionate about patient care, who are interested in oncology. And to Dr. White's point, I think there's something really special about cancer patients. And our role is actually quite privileged because we get to spend a lot of time with our patients. So I think first and foremost, people who really care about oncology patients. And then, I think things in the application that reflect that, are people doing things that are very focused on clinical care? Do they have good clinical grades? Have they spent time doing things in service to patients? And then I think there's also a component of radiation oncology that's quite cerebral. So there's a lot of people quite interested in research in all different domains. It doesn't have to be like scientific research or physics-based research or lab-based research. It could be clinical research. As Dr. Diaz mentioned, she's very involved with DEI work, and I think that's an area that's of rapid growth in radiation oncology. So really any place that you feel passionate about trying to expand knowledge within medicine, we love to see that on an application.
Thank you, Dr. Jimenez. Dr. Mattis, do you want to talk a little bit about opportunities for the medical students to get involved through ASCO?
Sure, sounds good. So So I think as a medical student, it's just very important to be proactive in general. I think when I was a student, I was relatively naive, and I sort of thought that, well, I'd figure out what I want to go into as a third and fourth year when I'm doing my rotations. I'm going to see everything then. But actually, you only see relatively few number of specialties then, and a lot of times you miss the more subspecialized ones like radiation oncology and others as well. So I think it's good to read about different specialties, to try to be proactive about reaching out to people. I have students emailing me all the time asking if they can come shadow for a day. um, and just most people will respond if you express an interest in their field, either clinically or through research or whatever. So and actually there's, I think, even though it may seem busy as a first and second year medical student, it gets a lot harder to do these sort of extracurricular things, do some extra shadowing when you're a third or fourth year. So, as early as you can, just, get yourself out there and explore different things. And there are some structured programs to do that. In most medical schools, between the first and second year, there tends to be, at least 6 to 8 weeks where, you have free to sort of choose your own adventure. A lot of people do research in that time, and, that can definitely be a good use of your time, especially if you can kind of follow through with a project to the point of being a co-author on an abstract or a publication or whatnot. Other people use that opportunity for clinical exposure. So for instance, ASCO, the American Society of Clinical Oncology, has an oncology summer internship program, which isn't available at every medical school in the country, but it's available at a few. That's one funded opportunity for clinical exposure. So ASTRO, which is the American Society for Radiation Oncology. It's kind of the largest radiation oncology specialty society in the US. They also have a medical student fellowship, which is a program for medical students who are from backgrounds historically underrepresented in medicine, to get a funded research experience, kind of with a mentor of your choosing. And that program just expanded, and I think there's 10 or so slots in the past year that they offered, and that they'll be offering every year. And there's other programs too. There's a group called the Radiologic Society of North America, which has like a medical student research grant, which can fund radiation oncology research as well. The American College of Radiology has some programs that apply for if you're interested in radiation oncology. So, a lot of these specialty societies have good formal programs to get some funding for the summer. Or you could just find a mentor at your own institution. A lot of medical school dean's offices have research funding too. So I think the key take-home message is just be proactive, do some shadowing, and you'll learn a lot.
Thank you, Dr. Martinez. I would just add, particularly that even if you don't have a radiation oncology program at your own institution, feel free to reach out to other institutions. Right now, several institutions have programs. For example, I'm talking about, for example, OSU. At OSU, we have a program for students who don't have a home program, and they can come and work with us. And there are some internship opportunities, paid internship opportunities to come and rotate with us if you don't have a home program, because we know it's an extra challenge. So there are some opportunities out there. Just keep your eyes open and looking for them.
I'll mention a couple other things too. There's a bunch of mentorship programs out there too. For instance, ARROW, basically the National Resident Radiation Oncology Society. They have a program, in particular for students underrepresented in medicine. ASTRO has a mentorship program. The Society of Women in Radiation Oncology has a mentorship program. So there's, there's a lot of these programs out there to find mentors, even if you don't necessarily have a department or a lot of mentors at your own school.
And ASCO has one as well. I don't know if you mentioned that one, but ASCO has one too. So, I would really encourage, if you're interested at all in radiation oncology and you're not really sure where to begin, and there may not be a program at your institution, just Google ASTRO or ASCO or RSNA. They all have programs for medical students, and they will provide some stipend. And they also, in many cases, will pair you with a mentor. So you don't have to find your own mentor. On the ASTRO site, for example, they list people who are looking to be mentors to students who are underrepresented in medicine. And I bet probably all of us are listed on there, but there are many others. And so you can check by state and by program, and then ASCO will actually pair you with someone as well. So if you're not sure who would be a good mentor for you, you can just tell them what your geographic restrictions are, and sometimes they'll help you find one. So I think that the intent is to keep the bar low so that it's not so difficult for you to find the people that you're looking for. And certainly I've mentored people who have been interested in radiation oncology and then decided to go into medical oncology or decided to go into another field. And that's totally okay too. I think that they just, residency programs want to see that you tried things, that you branched out, yet you tried to explore things, even if it didn't end up being the particular specialty that you wanted to do. I think we all feel like we learn tremendously from our colleagues in other fields. And that's true for these summer internships as well. So just don't be afraid to reach out and to explore some of those things.
Thank you, Dr. Jimenez. Okay, so one of the questions on the chat, how many publications is required to apply or be competitive?
So I'll start, and then I would actually really like to hear what Dr. Madison, Dr. Wade, and Dr. Diaz think, but I would say 0. I would say the number of publications required to apply and be competitive is 0. I think historically, radiation oncology was very research focused, and advisors would advise people to take a year off just to do research so that they could show that they had publications prior to their application. But I think things have changed quite a lot in radiation oncology. And what we're really looking for, to my earlier point, is people who really care about patients and want to take excellent care of them. And so I think that trying to show that you are advancing the field by knowledge in some way is helpful, but it doesn't necessarily have to come in the form of a publication. So I think if you can talk in a clear manner about the work that you've done in any space, whether it's research, whether it's community outreach, whatever it is that you're passionate about, and you can show where you think that has taught you something about wanting to be a really good radiation oncologist, I think that's quite compelling. So I wouldn't limit yourself if you don't have a lot of publications or any publications, as long as you think that the field is the right field for you.
Thank you, Dr. Jimenez. I agree. I think there is not a minimum number. I think well-rounded an application that shows that you excel and that you care about patients, not only publications, the volunteering activities, it's more than one thing. It's not only research, it's not only the number of publications. And as Dr. Jimenez said, yes, in the past, there was a strong focus, but I don't think it's necessarily the case anymore.
Yeah, I mean, I generally agree also. I think, as a medical student applying for any residency program, not just radiation oncology, I mean, it's helpful to do things that distinguish yourself, in some way, and show your competence and your ability to see projects through to completion, and that that you care about the work that you're doing. So, that can be in research, that can be in other areas as well.
What is the role of radiation oncology, and how does it differ from radiology and interventional radiology?
I guess I'll take a stab at that one. Radiation oncology is what we've been talking about, the care of cancer patients using a modality of radiation. One of the things when I was trying to do my research about the field was I had that same question. How is this different from radiology? And I shadowed a radiologist, and they typically just, they diagnose diseases based off of radiographic images. And for me, I preferred, the option of radiation oncology because I felt that this field gave me the opportunity, as we've been talking about, to have an impact in tapping into patient care more, and talking to patients, talking to their families, guiding them through the walk of radiation treatment. And one of the unique opportunities that our field has is that you have to be really engaged when working in a team. One of the things that we can't do compared to Dr. Matthews is we can't just open up a radiation oncology practice and call it, and that's it. We need so many people part of this team in order to do what we do best. We need the help of the nurses, of course. We need the help of the dosimetrists. The dosimetrists actually help us create a optimized great plan so that we give the radiation right where it needs to go to the tumor, and try to avoid as much as we can those normal structures. We need the physicists. They do quality checks to make sure that it's going to be safe to give this radiation to this to the site, that the machine is working adequately. We also need, and we go to different multidisciplinary tumor boards as well. So we work with radiologists, the medical oncologists, the surgeons, the pathologists, so many people part of the team to that one patient so that we can treat them and make sure that they get that treatment that they deserve. So if you are interested in being on a really impactful team to treat patients, I think radiation oncology is a great field for you.
I'll just add it does get confusing with all the radiology and radiation oncology, but actually they're totally different specialties, right? You don't go through radiology to get to radiation oncology. It's its own residency. So interventional radiology is kind of a branch off of radiology. It's very different. I mean, radiologists are, really just interpreting imaging, for the purpose of helping clinicians do their job better. Interventional radiologists are more proceduralists. They're using the imaging to do, various procedures that they do, biopsies and things like that. Radiation oncologists are really, we're clinicians. We're seeing patients. Everything we do is with patients, whereas the others do very little with patients. They're very different specialties. I mean, if you don't really like, taking care of patients too much directly, then, radiology or interventional radiology maybe better fits. But if you like spending a lot of time with patients, helping them through treatment, working through differential diagnoses, managing side effects, we're involved in all of those things.
And one thing I'll add to that is I think that radiation oncologists, even though it's not officially part of our job description, end up being teachers. So we spend a lot of time with patients explaining to them what their cancer is, what that means, what their treatment options are, what that means, to explain to a patient what is chemotherapy and how is it different from radiation therapy. These are the kinds of things that we hear from patients frequently. And this is not to cast aspersions on our surgical and medical oncology colleagues, but I think that they often have less time to spend with patients than we do. And so we end up stepping into the role of explaining to patients everything about their care, which I think is quite a privilege, one. And two, I think it also fosters a lot of very close relationships with patients and families. And so I think it's quite privileged to be in the job that we're in, because we really do foster very strong bonds with our patients and see them through not just the difficult parts of treatment, as Dr. White was saying, but beyond that, when they come back and follow up, when they're survivors, when they're dealing with side effects, when they're worried about cancer recurrence. And so I think a radiologist or interventional radiologist just would never have the privilege to be able to do that level of teaching and really clinical engagement with patients and families.
Okay, thank you so much. So similar, different question. Why did you choose radiation oncology over medical oncology?
So I'll start and then I'll let others jump in. But so I think medical oncology is fascinating, and I feel quite lucky to be in proximation to working with medical oncologists every day. But the reason why I chose radiation oncology over medical oncology is because I think as a physician, I was really driven to want to do something to help patients, like to have a very active role, more like a surgeon, that there's a procedure or an intervention or something that I can offer somebody that I can do to try to improve their chance of cure or their quality of life. And so I think there's something very creative and procedural that is the backbone of radiation oncology, that we're thinking about where tumors are located anatomically, and we're thinking about what's the best approach to deliver radiation to that area, and how quickly can I do it, and if I do it quickly, what do I think the side effects are going to be? If I use this other approach, what do I think the side effects are going to be for that patient? So it's really thinking very anatomically, like surgery, but thinking about it through three-dimensional imaging instead of the patient on the OR table. And so for me, that was quite appealing.
I'll add that for me personally, I love the technological aspect of radiation oncology. To kind of just picture that these invisible beams are coming in and curing cancer patients is really incredible. And so learning about that as I go through residency has been really a joy. And it's interesting too, as you think about the different specialties, radiation oncology has the longest amount of training in oncology itself compared to our colleagues in medical oncology and surgical oncology. So we're really equipped and trained to be able to take care of our patients.
I'll also add that, I think you really have to look at what the different treatment modalities are doing for the patients. And I think that's what kind of led me more towards radiation oncology. And also the types of patients that you're seeing. As a medical oncologist, most of the time you're caring for more patients with stage 4, incurable cancers, and you're helping them more towards the end of life. Whereas more of radiation oncology and surgical oncology is a little bit more the curable patients, where you're trying to, get rid of a tumor completely. And I think, we do a lot of palliative radiation also, which is very important. And, even in that situation, I think it's, it's nice because a lot of times our palliative radiation doesn't cause a lot of side effects and does, help with the symptoms. Whereas, you learn about all these drugs, chemotherapies, targeted therapies, things like that. And, a lot of times that they cause a lot of toxicity, and, the response rates are only on the order at, 20 to 40%, and, depending on the situation. So, I don't know. I kind of like the therapeutic ratio, you could kind of say, of radiation and what it does, the way it can preserve quality of life, both in the curable and the incurable patients.
My answer would be very similar to what Dr. Maris just said. I think I like seeing the patients, treating them in the definitive setting, and also the patients that we treat with stage 4, that we treat for palliation. It's so gratifying seeing how a few fractions of radiation can improve their quality of life and how happy they are. It's so gratifying that it's just a few days and they do so great. So that's probably the most important factor for me. The other thing is I love clinic. I love talking to patients for a long time. And I know medical oncologists do, but I want to stay in the outpatient setting. I do not see myself doing inpatients. We do, as we mentioned earlier, we are consultants, but I'm not, I prefer mostly the outpatient setting. Okay, so would you say that, another question, would you say that more than 80% of your time is spent in the computer creating the plans for patients? from what it has been described, it seems that you only see patients during OTB initial consults or if a procedure is needed.
I can start with that, Dr. Diaz, and then you can jump in. But I would say that the vast majority of the time that we are working is in direct patient care. So, for example, my clinic today, I saw 12 new consults, all with breast cancer. I spent basically the entire day seeing new patients, talking to them, counseling them. And I probably spent, I don't know, maybe an hour or two in front of the computer doing contouring. So there are days where you might have a particularly complicated case where you'd be spending more time at the computer. But I would say the vast majority of the time that we are at work, we are actively seeing patients in clinic. And to Dr. White's point, we have dosimetrists whose job it is to essentially be an extra set of arms for us. So while we're seeing patients in clinic, we have a dosimetrist who is trying to follow the instructions that we've given them about the kind of radiation plan that we'd like to generate for a patient. And they're behind the scenes creating a bunch of rough drafts for us to look at. And so that means that we don't have to be at the computer 80% of the time. Dosimetrists probably have to be at their computer 80% of the time, but we are fortunate to be able to be in direct patient contact most of our day.
Yeah, I would agree. I would probably say it's 80-20. 80 doing clinical contact, direct patient contact. Yes, I think I spend probably 3 hours a week approximately on contours, planning, reviewing images. 3 to 3.5 hours a week. That's probably, of course, when I was a resident, I probably spent significantly more hours while I learned all the details about contouring, but it's still the bulk of the work week is mostly seeing patients in clinic. Okay, any other question or comments? So I have another one here. Any advice on potentially having to soap into radiation oncology?
So I don't know what prompted this particular question. I would say, soaping we usually think about as people not having matched in the field that they are most interested in, and then they're trying to enter another field in order to attain a residency spot. So I wouldn't necessarily think about radiation oncology as like a second fallback. But I think that sometimes that does happen. And anytime you're thinking about entering the SOAP for a field, you certainly want to know the field as best you can and really be able to articulate why that would be a good second option in case you weren't interested or weren't able to pursue your first choice option. But I would say if you're thinking about it because you are worried that you may not be competitive for the radiation oncology match, I would just want to strongly encourage you to apply to radiation oncology and to reach out to any of us or to anyone at your institution who can help provide some advice and guidance about the process and really help you feel as confident and prepared as possible to go through the regular match. We need a more diverse specialty. We need people just like all of you to join radiation oncology. And so if it is a field that you're interested in, there are many of us who are happy to meet with you, happy to mentor and provide advice so that you can put your very best foot forward and make our field more diverse and more interesting, and so that we can better serve our patients. So if the question is coming from a place of worry about not matching, please do not hesitate to reach out to any of us, because I really do think that there is a true acknowledgement in medicine, but particularly in oncology and radiation oncology, that we need to diversify the physicians that provide care for our patients, and that doing so is the right thing to do ethically, it's the right thing to do morally, but like it's also much more joyful to come to work and have a diverse workforce and people that bring something unique to our field. So again, just trying to encourage all of you, please reach out to us if we can be helpful.
And there is one last question. Any advice for IMG students applying to Radonc? So I can start. So I'm an IMG, and I started radiation oncology in 2010. So it was a different era from what it is right now. All I can tell you is that it is not impossible. That basically you just have to excel. Basically the same things that we talk about, what makes a great applicant applies to an IMG. But probably it's true that you will probably have to shine even more and have something in your application that makes you unique, something that it's very different, and show that you are an excellent candidate, and that having some clinical experience in the US is very important, just to make sure to know that you know a little bit about the system here. And also, if you have had some clinical experience here, it's more likely that you will have a mentor here, that you will create some connections, someone to work with who can help you on showing you what the right path is to be able to have a competitive application. I think those are probably my tips. Dr. Jimenez, do you have any other?
I don't know that I have too many other tips. I think I would just say that our field has become more accessible to international medical grads recently. And so if you are sincerely interested in radiation oncology, please don't be afraid to apply. I think sometimes the concern from a program director side really has to do with, depending on the international student, is about English proficiency, the ability to communicate well with colleagues, both in written and verbal form, if English is not your first language. So really trying to buff up your personal statement, make sure that looks really clean and really clear if English is not your first language, I think is important. But again, I think the field much more accessible for international medical grads than it has been in many years. And so I would sincerely encourage your application.
And the last thing is, how would we reach out to the doctors on the panel? So I don't know if Cameron, we can share the emails. I would put them in the chat, but I'm not sure if once we close the Zoom session, the emails will disappear. I think we can potentially share them to those that have signed up, the emails, and also the links I was not able to share. Okay, thank you, everyone. Thank you to all of you thank you to the panelists, and thank you for the students for joining us tonight. And please feel free to reach out if you have any questions. Thank you. Bye.
Good night.